Somehow it is paradoxical. You would think that hot snare is safer than cold snare for those patients, and it's the other way around.
Welcome to a live recording of the ESGE podcast, Endoscopy Unplugged. Join us each month to hear the latest from European experts and where we'll discuss relevant clinical topics and provide you with tips and tricks, practical scientific evidence, and pearls of wisdom to inform your endoscopy practice. So please subscribe wherever you get your podcasts and join us as we advance GI endoscopy care.
Hello, everyone, and welcome to episode 7 of ESG's podcast, Endoscopy Unplugged. Today we have a very special episode for you because we are recording live on the Spotlight stage at ESG Days 2026 in Milan, Italy. As you know, my name is Ian Grelnick, past president of the ESGE, and I'm your host. Today's podcast is titled Snare Smart, Cold and Hot Techniques for Colon Polyp Resection. And my guest is Professor Maria Pellise, head of endoscopy at the Hospital Clinic of Barcelona and associate professor at the University of Barcelona. Welcome, Maria, to the podcast.
Hi, hello.
It's great to have you here.
It's really great, and here in the spotlight even more.
Exactly. We're having a great time here in Milan at ESG Days. It's been fantastic. Over 6,000 participants here. It's unbelievable.
Unbelievable, and everything is so lively, and there is so much activity everywhere.
Absolutely. So listen, before we get into this, how did you get into endoscopy?
That's nice. I think endoscopy provided me the exact balance that I needed between clinics and surgery, let's say. So I felt that endoscopy was perfect because you could solve things very quick, and I loved it.
And you did some advanced training in endoscopy, right?
Yes, I first started doing US. This was my PhD was in US, which I loved.
I didn't know that, really?
Yes,
okay.
Which I loved it. I really loved it. And then I had a terrible illness, and then I was disabled, a little bit disabled, physically disabled.
Really?
Yes, so I needed to not do so much endoscopy.
Okay.
And that was when the screening program of colorectal cancer program was starting. So I thought
in Barcelona?
And everywhere a little bit, like in 2009, 8.
Okay.
And I thought it was the perfect opportunity to put together my endoscopic knowledge in other things that were not so physically demanding. And that's why I moved more towards high-risk conditions, screening, and polypectomy.
Okay.
And after a few years, I went to Australia, where I was a fellow with Michael Berg, and there I could learn very much to manage large lesions and EMR and all this stuff.
Okay. Well, today we're gonna talk about cold and hot snare for colon polyps. So let's get into this. And if we're looking sort of at a big picture, how do you decide when you're doing your colonoscopy? How do you decide whether a polyp is appropriate for cold snare versus hot snare resection?
So I think that now things are quite clear, and there is a very easy message. Most of the polyps will be removed with cold snare. So cold snare is our best ally, and we have to have it all the time.
Okay.
But basically, for polyps that are smaller than 10 millimeters, there is no doubt.
Smaller than?
10.
Okay.
That there is no doubt. When it's to 10 to 20, here it's a little bit more, you have to do a better choice, and then you will also look at pedunculated polyps.
Yep.
Here, if they are really small, sometimes you have very small pedunculated polyps, I will continue to do cold snaring, but if they are a little bit larger, this wouldn't be a good choice.
Because of the vasculature within the stalk.
Exactly.
Okay. So we'll get more to that in just a little bit. So cold snare basically for everything, or where? Because I still see people will be using biopsy forceps.
No.
Okay, exactly. That's what I want you to talk about. So biopsy forceps, where are we today? Should we be getting rid of those as part of polypectomy?
No, I don't think we have to be absolute with anything. We need to have many tools and know that some situations need different tools. It is true that for very small polyps, like less than 3 millimeters, sometimes they are in a place that is really difficult to have a good stability, and you need to use your biopsy forceps. Also, when you have a recurrence, for example, on a very fibrotic area, sometimes a biopsy forceps can also help you a lot. So I would never say that it's an absolute thing, but for most of the cases, you should be using cold snaring.
Okay. So let me ask you a little bit more, dive a little bit deeper in terms of sizing. I'm doing a colonoscopy. I see a sessile polyp maybe in the right colon, and I'm estimating it at maybe 12 or 15 millimeters in size. It looks to me by characterization, this is a tubular adenoma. There's nothing special about it. Do you have any problems taking that out? Cold.
I have to say that I go to cold more and more because of the safety part of it. But it is true that when lesions get a little bit larger, like you were saying, the risk of containing cancer increases a little bit, but it's still very low. So here, if you think that a lesion can have cancer or even a little bit of suspicion, you shouldn't be removing it with cold snaring, because cold snaring, the plane of resection is the muscularis mucosa.
It's more shallow.
It's more shallow. So then there is a risk of not doing a complete resection. And in those cases, you should elevate the lesion and use diathermy that will help you to go to a deeper plane.
Okay, so you are, but what about if I were just to inject underneath and take it out with cold still?
It's still the same, because the plane of when you cut through with the snare, we see that most of the times the plane will be the muscularis mucosa or the lamina propria. So you will only be in the submucosa in 20% of the cases.
Okay, so walk us through sort of like a step-by-step technique. What's the optimal cold snare polypectomy?
So the first thing, as always, is that you need to be very stable and you have it in a good position.
Which is where?
Which is where? This is at 6 o'clock position.
Okay.
And this is important because I think that cold snaring of small polyps is the perfect scenario to train yourself to do good tip control.
Okay.
Sometimes it's much difficult to remove a very tiny polyp than a large one.
I agree with you.
And you would really feel like you are stupid because it's a nightmare.
Yeah.
And you see this small thing that is bumping from one side to the other. But it's the perfect scenario to say, well, if I do that properly, then I will be able to remove whatever, even with an ESD. And so I think that we have to think that it is a big challenge.
All right, so let me challenge you. So let's say you find that small polyp, 4, 5, 6 millimeters. You're going to take it out with your cold snare, but it's located up at the 12 o'clock position. Are you rotating the scope? Are you moving the patient? Okay. What do you do?
So the first thing is that you need to have a straight scope. So if you have a straight scope, you will have a good control. Sometimes you don't have a straight scope. So the first thing is try to have a straight scope.
Use your loops.
Reduce your loops and make sure that the movements that you do with the scope have a translation one-to-one to the tip of the scope. That is the way that you know it. The other way that you will know that you have a straight scope is that you just take your hand out from it, the right hand, and you see if the scope is really rigid or it is floppy. If it's floppy, everything is all right. If it's very rigid, probably you don't have a straight scope. The next thing, you can look at how far away you are from the anal verge to see if you are in a proper position. In case you don't have a straight scope, take your time to have a straight scope.
Okay.
And then once you have it, you will turn it, as you will say it, and you will be able to put the polyp wherever you want to put it.
So you're going to rotate your scope to bring that polyp to the 6 o'clock position.
Exactly.
Do you sometimes need to have your nurse or a trainee hold your scope in place?
No, what you sometimes need is some pressure in your belly because there is looping and you need that pressure to make really sure that you can have that. Sometimes you need to roll the patient, and sometimes it is true that there are some positions where you really can't do it. So then you have to do the best you can.
Okay, but the optimal position, at least, of positioning that polyp is at the 6 o'clock position. Okay, next step, what do? You got in the 6 o'clock position.
Next step, it is important the snare, because if you are going to remove a tiny polyp, 3 millimeters, 5 millimeters, and you are using a 50 millimeter snare, it's not going to work. So you need to have a snare that has the size that is appropriate for the polyp. So for the small polyps we are talking, 10 millimeters. That's a good snare. And why? Because with cold snaring, you are going to put the snare, the lesion just in the middle of the snare, and you're going to push down the snare with your big wheel to make sure that you have a parallel plane, and then you will do a guillotine effect. You will cut through with this guillotine effect. So you need to make sure that you have surrounding normal mucosa around the polyp to make sure that you do a complete resection.
So you want to leave a rim of normal mucosa around that polyp when you resect it, right?
Yeah, it's that image of a fried egg that you have in the middle, the yeast and the white thing in the surrounding. That's the perfect
I mean, tell us what type of snare do you usually use for cold snaring?
So,
aside from the size that you talked about.
So it has been said that if you have a thin wire, it's better to guillotine. But to be true, it's true that it makes it easier, but you also can do it with a braided normal snare. I don't think that it really makes a big difference in many of the cases. You need that the snare is stiff. This is true that you need a stiff snare.
What about its shape?
If it is oval or round, that will facilitate to have the lesion in the middle, but also the other ones are okay. I think that at the end, you need to get used to the one that you have and then work with it.
So I do the same thing. I use a small 9mm, 10mm size, round, stiff wire, thin wire. It's like cheese, it's a cheese wire. People talk about the bubble sign. So you've resected this. Do you then use your water jet to basically inject water into the base there?
Totally. I think this is the way you work. I think that the water jet is like our third hand. So we have to be using it all the time. It helps you to clean first, and then you have an optical diagnosis, quick optical diagnosis. Then you remove the polyp, and then again with the water jet, you have this bubble sign that if you see that the submucosa takes the liquid, you are in a good plane, and then also you will see like the borders of the defect will go. You will see them sharply, and you will be sure that you have removed the lesion. And then sometimes you will have bleeding. You have to know that intraprocedural bleeding is very normal with this technique. You don't have to take care about it. You just need to move forward and forget about it. And well, of course, then you can, after you go back, you can see if it's still bleeding, but it never happens. It always stops.
It's very rare with cold snaring. Even in patients who are taking anticoagulants, it's very rare.
And even in small pedunculated lesions also is very rare.
Correct. Do you photograph the image, the polyp before and after, and put that into the patient's report?
Yes. I think it is important, but here we need some help from the industry, and I think it's going to come in the next years to help us to better document these polyps and know which one corresponds to which one, to annotate the image.
Yeah, okay. I mean, I do that. I do it at this point because of more medical legal, that I'm saying here, look, here's the polyp, and now here's what was there after I resected that polyp. All right, so let's do the same thing now, step by step, hot snare.
Hot snare. So when are we going to use hot snare? We are going to use hot snare for those lesions that are pedunculated and that are larger than 10. For those lesions that are sessile and are more than 15 probably, or more than 12. And also whenever you have a doubt that the lesion can have something that is not totally normal, it's better that then you use saline or whatever injectate to elevate the lesion, and you do hot snare. For hot snare, you need a braided snare because you need diathermy effect to go through the snare. And then you will probably use a larger snare, but you can also have a 10mm snare if the polyp is not so big. And you can also do underwater EMR for that kind of lesions as well, for 15mm lesion. And in that case, what will change is that because of the diathermy effect, you want to do a tenting. You will do the other way around. You will just desufflate, you will take the air out of the colon, and then you will do tenting to make sure that you just separate.
To pull it away from the wall.
To pull it away from the wall.
Because you don't want to transmit the thermal energy.
Exactly.
Right, okay. So, and you're using like a special, what type of a diathermy unit are you using, or settings that you're using today?
So it is true that all these EndoCAT or any computer-assisted and diathermy are more safe probably and better to be used. So that's the one we usually use, the EndoCAT in our case with Bio3, but there are other ones. And we use the yellow pedal for that.
Yes. You're basically, it's a blended cut, right? So you're cutting and you're coagulating because the machine can actually sense the resistance that's there. Okay. And that's what we should be using, and you use the yellow pedal.
Exactly.
Okay. So what about those polyps, though, that have these big, thick stalks? Are you pre-injecting with some epinephrine? Are you prophylactically clipping them and then taking off the polyp? What do you do in those situations?
That's curious. It's an interesting thing because it's a quite common situation and there is not so much evidence and there is some controversial evidence. So we inject, and I think that this is clear that doing a prophylactic maneuver is convenient for these polyps that have a stalk that is larger than 1 centimeter.
But you inject with like what, dilute epinephrine?
So we use epinephrine diluted with saline. But
into the stalk?
Into the stalk.
Okay.
I have to say that I do a little bit of an EMR in those cases very often.
Okay.
So I do it into the stalk, but also on the basis of the stalk.
Okay.
And what I usually do is that, depending on the stalk, but very often I try to go really to the basis of the pedunculum. So it's a little bit like if I was doing an EMR, because I feel that this is safer in case there is invasive cancer, because most of the T1 cancers, 50% of the T1 cancers are located in pedunculated polyps. And here is where we have more often OOPS cancers, that we are not able to predict it beforehand. So we have to remember that when there is a pedunculated lesion that is larger than 20 millimeters, especially, the probability of having a cancer is probably one of the most important. So you need to remember that and do an en bloc resection of this lesion, trying to be as far away from the head of the polyp as
because
possible.
You want the pathologist to evaluate with the Haggett score, correct?
Exactly.
Okay. Does your nurse, or do you put a pin into the stalk of the polyp, because that can retract once you put it into the bottle?
Exactly. So this is clearly how it has been demonstrated that it works, but we don't do it.
Okay. Well, you're honest.
No, because
we don't either. So.
I think nobody does it, but the pathologists really ask us to do it. But
well, I mean, one of my mentors, Fred Weinstein, who is now deceased, was a gastroenterologist but also a pathologist, and he did pin all the pedicles because of that reason, and he wanted to make sure that there was no invasive cancer through the pedicle.
Yeah, we did a consensus with the pathologist, and we also stated to do that. The reality is we finally don't do it, but most of the time they are able to assess it because they are really good. What for them is confronting is that sometimes we label lesions as pedunculated, and they are pseudopedunculated. Those are sessile lesions that have done a pseudopedunculum. And this is very important that we learn to differentiate it. And whenever you are not totally sure that this is a pedunculate lesion, it's better that you describe it as a pseudopedunculated, because then it will be a sessile lesion, and that completely changes the approach once you have to rate the risk factors in case there is a T1 cancer.
What about, do you prophylactically clip stalks sometimes?
So I usually do epinephrine and then I cut and then I do clipping, not the other way around.
Okay.
But it is true that I do a lot of patients that have juvenile polyposis and amatomatous polyps.
Yep.
So in those cases, sometimes I do it the other way around because they have really long pedunculums. So I know that I can really put the clip and then cut being away from the clip.
Yeah, if you're going to prophylactically clip, just always make sure you make your cut above the clip, not below it.
Exactly. And not close either because of the diathermy.
Exactly. You could transmit the thermal energy. I sort of do it on a case-by-case basis.
Totally.
The problem is sometimes when you don't put that on, because sometimes it's hard to put the clip on. It may be in a funny position. It's not always straightforward, at least in my experience, but sometimes it'll bleed, and then you're sort of, oh man, why didn't I put that on there before? But sometimes I'll clip it after, sometimes I'll clip it before. But
usually, even if it bleeds, you have time to do it afterwards.
You do.
And if it is a pedunculated lesion, you have a good position. But it is true that depending on the position, you need to consider one important thing about clipping a pedunculated lesion is that you need to make sure that the clip will compress the artery. So don't put it in the top of the pedunculum because this is not. You need to compress.
You want to go to the base. Exactly.
Go to the base and compress.
Absolutely. And sometimes you may need to have a couple there.
And that's why sometimes I do like an EMR because then I close the defect.
Okay. What potential complications are there with cold or hot snare?
I think that for the small polyps, we are talking about a very safe technique anyway. But the thing is that it's something that we do very often. So even if it's in percentages safe, it can be numbers then important, because even if it happens only 1 every 1,000, if you do thousands of them, then it's going to happen. So that's why we need to have that in mind and be sure of the general context of the patient. And so the major risk is bleeding, and what we are feared of is not the intraprocedural bleeding that we will be able to treat, but the post-procedural bleeding. And this, I think, is something that we have to have in mind. That's why cold snaring is much safer than any other of the techniques.
So with hot snaring, what do we need to worry about? Aside from, we've touched a little bit about thermal injury and maybe a post-polypectomy syndrome in those situations. What else?
You always can do perforations. That's our major fear, and you can do that also with cold snaring. You have to know it. So it's not something that happens very often, but it can happen. It's not impossible, especially with very fragile patients, probably. So if you do a good inspection of the defect, as we were saying before with the bubble sign, then if there is something that is not okay, you always can clip it and solve it. So the thing is about doing as most of what you can do during the procedure to avoid delayed complications. Those are the ones that we don't want to have.
Can I ask you a couple things on patient factors? In other words, before you even start the colonoscopy, you're looking at the patient's age, potential comorbidities, medications that they're on. How does that potentially influence your potential decisions with resection when you get into the colon?
I think we have to get more and more used to take that into account and to have a general framing of what we are doing. And I think that one question is if it is convenient to be treating 85 years old patients with small polyps, because even if the risk is low, I don't think that their benefit is any, but this is something that we need to work on it as a endoscopy community. Yeah. And I think we need to run trials to assess that.
And we know that patients are living longer, and we don't know completely, I mean, we don't know always when to stop, right?
And then we are talking about prevention. We are not treating anything. We are preventing something.
Correct.
So we need to have that in mind. But once this is clear, the second thing that is very important is anticoagulant and antiplatelet treatment. This is a very important factor here. Somehow it is paradoxical. You would think that hot snare is safer than cold snare for those patients, and it's the other way around. So if one patient is anticoagulated or in antiplatelet treatment, I will favor even more cold snaring.
Absolutely.
And this is something, maybe it's not the first thing it's not so intuitive, but this is clear.
Absolutely, I agree. Because after we hot snare, I mean, there's an ulcer that develops there. It gets larger, and that has a greater tendency to bleed, especially on patients who are on some type of an antithrombotic agent.
Exactly. With cold snare, you have a nasty wound in the moment you do it.
Yes.
But it's just superficial. It will heal. With hot snaring, you have a nice wound. It looks very nice, but there is the diathermic effect that will transform that into an ulcer.
Yep.
And here is where the problem will appear.
So as we're starting to get to the end of this podcast, I do want to ask you about training. What are your recommendations in terms of how does a trainee or a young endoscopist become competent in snare resection of polyps?
Yes, now there is a very nice tool. I just tried it now in this Congress. This is one of the good things as well about Congresses as well. It's to train on therapeutic, and there is a very nice model for training on polypectomy, but there are several models to train with polypectomy, and you can even do your own one, because it's just with a box and an endoscope. It's easy, because what you need to do is tip control and learn to put your polyp at 6 o'clock position, and then just train in a gym, let's say. No? You know that in UK they have developed this DOPS
That's exactly what I was just going to ask you.
Which I think is really interesting, and we are trying to apply it as well at home now.
Yeah, for our podcast listeners, it's really important that there is DOPS, which the UK has developed, that objectively is a tool to objectively evaluate the skills, not just of the performance of colonoscopy, but of polypectomy as well. And ESG is also going to be working on these types of objective measures to certify competency. I think it's extremely important as we go forward, because these are the people who will be taking care of us one day, right?
Yes.
First of all, this has been a great conversation. I have my yellow glasses. You have your orange glasses, which I really like, and they're very similar. So this is very cool. But tell us, when you're not doing endoscopy, what do you do? What does Professor Pellise do in her free time or activities?
Is there life after endoscopy?
Yes, there better be. Yes.
So yeah, I do. I like very much family and friends time. So I do a lot of that kind of social thing because I like very much having people at home for lunch, and then I like very much nature and walk in the woods and the seaside. I am very much of a nature person.
Yeah, in Barcelona you have the sea.
So, yeah, and we have the sea and we have the mountains, and I love that.
Yeah. So it's for these lunches, like, are you a big cook? Do you cook for these lunches?
No, it's even better. I have an excellent husband.
He's the cook in the family?
He's the cook
Really?
for this kind of social things. I am the cook for the everyday, so I am just there enjoying people.
I hope my wife is not listening to this podcast because she'll get the wrong idea. I'll have to start cooking for the family holidays and the dinners. And my wife is an outstanding cook, so I would not stand up to that.
Yes.
Listen, I want to thank you again for being on this very special podcast that we recorded live from ESG Days 2026 in Milan. Thank you again, Maria Pellise, for being my guest today. It's been great.
Thank you.
Thank you for listening to this episode of Endoscopy Unplugged. If you found this podcast useful, please subscribe wherever you get your podcasts. To find out more about the European Society of Gastrointestinal Endoscopy, for example, to browse our scientific publications, interact with our online learning portal, the ESG Academy, or learn about becoming a member of ESGE, visit our website, www.esge.com. And of course, your feedback is always valuable to us. So send us your thoughts via podcast at esg.com. Thanks for listening, and join us next time.